Good morning. In the interest of time, we're going to begin the presentation today. It's been presented and hosted by the Rheumatological Department from Charlotte McKexy. Dr. Ivy Anafi, one of our senior consultants doing a fellowship in rheumatology, will be giving us a presentation on vasculitis, and it will be specifically at the level of the fellows and the physicians in terms of an approach to vasculitis. Ivy, if you're ready to proceed.
All right, good morning, everyone. Thank you, Prof. Solomon, for the introduction. Let me confirm everybody can see my screen.
We can see it.
Okay, so the topic for my presentation today is vasculitis. It's quite a broad topic and somewhat complex, but I will do my best to do justice to the topic in the time allocated. I will look at the, we'll talk briefly about what vasculitis is, and then I will show you some case presentations of patients who had vasculitis and presented in varied ways. We'll look at the pathogenesis of vasculitis and then how it's classified. And then we'll also look at how to recognize vasculitis and how to manage it, and also discuss some new and emergent information on vasculitis. So vasculitis is inflammation of the blood vessels, and it causes necrosis of the blood vessels, resulting in destruction. It leads to occlusion of the blood vessels, which may be partial or complete, and this will result in ischemia of the dependent tissues. Also with vasculitis, it can cause thinning of the wall of the blood vessel, which leads to aneurysmal formation, and these can perforate, or you can have thrombus formation. When the aneurysm is formed, it's going to impair blood flow, either stasis or turbulence. And from Virchow's triad, we know this is a recipe for thrombus formation. Vasculitis has multi-system involvement. It involves various organ systems, and the presentation and manifestation is widespread. I'll take us briefly through 3 cases where patients had vasculitis and presented to various departments with varied presentations. The first one is that of a young female. She's currently 25 years old, diagnosed with hypertension at age 19. And on evaluation of her hypertension as a possible secondary hypertension, she was noted to have decreased pulses on the right side, the radial, brachial, femoral, and carotid pulses. And also there was a discrepancy in the blood pressures in both arms. On blood investigation, she was noted to have increased acute phase reactants with ESR of 92. Her renal function was normal. She was A&E negative. Her chest X-ray showed that increased cardiothoracic ratio, likely from her hypertension, and her renal ultrasound was normal. When they went on to do a CT angiogram for this patient, and it showed that she had circumferential wall thickening of the ascending aorta, the aortic arch, the right brachiocephalic trunk, the descending aorta, and abdominal aorta and its branches. And also there was an aneurysm that had been formed at the ascending aorta with some stenosis at the common iliac. I believe a majority of you in the audience can guess the diagnosis here. She was diagnosed with Takayasu's arteritis. She was managed with cyclophosphamide. Unfortunately, she was lost to follow-up for about 3 years and presented to us with a stroke recently. She had a left basal ganglia infarct, and she was also in heart failure. We treated her with cyclophosphamide. Unfortunately, for the period of her admission, there was a delay in getting an MR angiogram done and also a PET scan done. During that period, there was a delay. So we treated her with cyclophosphamide for active Takayasu's, and her hemiparesis resolved. She went out of heart failure. She was better. We discharged her. She is following up at the clinic, and the plan is to complete her induction treatment with cyclophosphamide and maintain her on disease-modifying anti-rheumatic drug agents and counsel her on the chronicity of the disease and the need to be compliant. Case 2 is that of a young gentleman who in childhood experienced recurrent upper respiratory disease and had had multiple grommets inserted, had had a tracheostomy for pharyngeal obstruction, and had developed collapse of his nasal septum and saddle nose deformity. And during his childhood, he also was noted to have a nodule on a CT of his lungs, and this was biopsied and showed granulomatous inflammation with necrotic vasculitis. And I'm believing that, and at that time, he also had a C-ANCA done. This diagnosis was actually done in Cape Town, and then he was C-ANCA positive. And I'm sure you can guess the diagnosis made here. He was diagnosed with granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis. He was treated with cyclophosphamide and was in remission. Recently came to us with recurrent lower limb rashes and necrotic ulcers and arthritis of his small joints. His acute phase reactant again raised with an ESR of 103, C-ANCA positive. We biopsied those lesions on the lower limbs, and it showed necrotizing vasculitis. He was managed with high-dose steroids. The rashes and ulcers have resolved, and he's currently being maintained on methotrexate, and prednisone is being tapered off. Case 3 is that of another female, 32 years, who presented to dermatology with widespread painful rash in her palms and on her feet, and had already developed gangrene of 2 digits. She had features of alopecia and arthritis, and on workup, her ANA was positive. She had positive antibodies to double-stranded DNA and Smith. She had hypocomplementemia. Her ANCA was done, that was negative. She was HIV negative. Her renal function was normal, and an echocardiogram was done to look for possible source of emboli that was also negative. Her lesions were biopsied, showed necrotizing vasculitis. She was also managed with glucocorticoids and cyclophosphamide. We chose to hit her hard because we saw this as an organ-threatening disease. She was already losing her limbs, so we gave her cyclophosphamide induction, which she completed. She's currently stable in remission and on methotrexate. So this shows the various ways that vasculitis can present. I just chose a few. There are other ways it can present. Let's look at the pathogenesis of vasculitis. The etiology remains largely unknown, but we know that it occurs via immune mechanisms, and there are 3 pathways that have been identified. It can occur as a cell-mediated inflammation, an immune complex-mediated inflammation, or ANCA-mediated. That's anti-neutrophil cytoplasmic antibodies. The diagram on the right, which I sourced from an article from Frontier Cardiovascular Medicine, seeks to help explain what actually happens. So with cell-mediated inflammation, this occurs usually in the large vessel arteritis, an example being giant cell arteritis. You have the blood vessel, you have the endothelium, and then your intima media and the adventitia. You have antigen-presenting cells, dendritic cells, macrophages resident in these in the adventitia and the media. So when there are foreign antigens in the blood vessel, for example, antigen proteins from drugs or infectious agents, these are recognized by the immune system. The antigen-presenting cells recognize them and present them to your naive T cells, and they activate your CD4 cells. Activated CD4 cells will now release cytokines, and especially interleukin-1 and interleukin-6, which cause inflammation and subsequent damage to the endothelium. And we know activated CD4 cells also will call for help, recruit more macrophages, recruit more monocytes, and recruit CD8 T cells and natural killer cells, which would exert direct cytotoxicity on your blood vessel wall and cause damage. The other thing that it does is that it enhances the production of your VEGF, your vascular endothelial growth factor, and your platelet-derived growth factor. And we know this is going to cause intimal hyperplasia and compromise the integrity of your endothelium. Then with immune complex mediated inflammation, you have the B cells producing antibodies in response to these foreign antigens, which may be drugs or microbial. They form complexes with these antigens, which are then deposited on the cell wall, on the endothelium. The deposition now activates your neutrophils and then causes degranulation of your neutrophils, release of reactive oxygen species and proteolytic enzymes, which will also destroy your endothelial lining. So the immune complex mediated mechanism occurs usually in your medium to small vessel vasculitis. It's also seen in your vasculitis associated with other autoimmune disease. For example, in SLE, where with that, the antigen is usually self-antigen. So you can have antibodies produced against the endothelial cells, and the body recognizes these as foreign and forms antibodies against them, forms complexes and deposits these complexes. The ANCA-mediated inflammation is presented well in the bottom picture B. So the neutrophil has normal enzymes in granules in the cytoplasm. That's the neutrophilic cytoplasmic enzymes. And the ones of importance to us in vasculitis is your myeloperoxidase and proteinase 3. For some reason, things go haywire in the immune system, and then your B cells produce antibodies to these normal enzymes in your cytoplasmic granules. And it causes the neutrophil to degranulate and release proteolytic enzymes to destroy and these destroy the endothelium. Also, the activation of the neutrophil activates your complement pathway, the alternate complement pathway, with subsequent formation of complement 5A, which we know is notorious for destruction. So this destroys your endothelium and also causes increased expression of endothelial tissue factor. And this is a very important pathway which researchers have done a lot of work on to look for new drugs for vasculitis. Right, so if you did a biopsy of tissue with vasculitis, this is what you're most likely to see. You see the fibrinoid necrosis in the center, and then infiltration of the vessel wall by inflammatory cells, neutrophils, mononuclear cells, or it could be giant cells where appropriate. And then there's what we call leukocytoclasis, where the neutrophils sort of disintegrate and release its contents, what they call nuclear dust, which you see around the vessel. And then you also see infiltration around the vessel, the perivascular infiltration around the vessel. So vasculitis broadly can be divided into primary and secondary. Primary vasculitis usually occurs independently, and your secondary vasculitis will occur as a feature of another established disease. Under this, we have vasculitis that's related to other systemic conditions. For example, your autoimmune conditions, rheumatoid arthritis, SLE, can have vasculitis associated with sarcoidosis, with inflammatory bowel disease. It may also be associated with, infections. And we know about HIV, vasculitis associated with hepatitis infection, especially B and C, syphilis, and then some fungal infections, and also mycobacteria. May be associated with malignancies and also with drugs. And the notorious drugs are propylthiouracil, which you use for thyroid treatment, and recreational drugs, it's mainly cocaine and amphetamines. The classification, which I believe most of us know, this diagram is probably familiar to a lot of us. The classification we use is the revised 2012 Chapel Hill classification criteria for vasculitis. So what it does is that it divides the vasculitis according to the size of the vessels. So you've got large vessel vasculitis, which comprise of Takayasu's arteritis that we saw a case of earlier, and also giant cell arteritis. And then your medium vessel vasculitis comprises of polyarteritis nodosa and Kawasaki disease, which we do not see here because it's mainly a disease of infants. Then when you get to your small vessel vasculitis, we've got two broad groups, your ANCA-associated small vessel vasculitis, and then the immune complex small vessel vasculitis. The ANCA-associated ones are your microscopic polyangiitis, your granulomatosis with polyangiitis, formerly called Wegener's granulomatosis, and then eosinophilic granulomatosis with polyangiitis, formerly known as Church-Strauss. And then under your immune complex small vessel vasculitis, you've got cryoglobulinic vasculitis, IgA vasculitis, formerly called Henoch-Schönlein-Pepper, and then hypocomplimentemic urticarial vasculitis. And then we've also got antiglomerular basement membrane disease, which occurs mainly at the capillary level. This next slide is more of an expansion of the 2012 Chapel Hill classification criteria, and they add these two Behçet's disease and Cogan's syndrome, which are classified as variable vessel vasculitis. These can affect any size of vessel, and also they talk about single organ vasculitis. An example is your primary CNS vasculitis, and then they also mention the vasculitis associated with systemic disease. We see our autoimmune diseases here and other chronic inflammatory diseases, and that from other probable etiology. And we see a list of infections and drugs and malignancies in that. So just a brief revision on ANCA. ANCA is anti-neutrophil cytoplasmic antibodies, and these are antibodies that are directed against proteins in the cytoplasmic granules of neutrophils and monocytes. There are two types, one found in the cytoplasm, which is given the prefix C, and this targets your proteinase 3 antigen, and it's seen in GPA. And the other type is found in the perinuclear area and is given the prefix P, and that targets myeloperoxidase antigen and seen in MPA and EGPA. The picture on the right shows immunofluorescent stains of these antibodies. So C, you can see the stain is more scattered in the cytoplasm, and P shows a more of a linear form showing the following the perinuclear distribution. So the time we have will not allow us to go through each and every vasculitic syndrome and describe it. So I just put up this table to help us revise some of the important features that will help us localize or diagnose some of the different types of vasculitis. So it's just a brief review of the things that will make you suspect the different types of vasculitis. So with giant cell arteritis, you usually have an elderly patient, male patient more than 50 years, and the presentation is usually complaints of headaches, usually in the temporal, localized to the temporal region. The temporal region may be tender, and then you may also be able to palpate thickened arteries. Visual loss is a serious complication that can occur. Usually your ESR will be increased in giant cell arteritis, and if you're able to obtain a biopsy of the temporal artery, you will note the granulomatous inflammation. They also present with jaw claudication, giant cell arteritis. Then Takayasu arteritis, like we saw in our case, usually occurs in young patients, more females, and they may have diminished or absent pulses on one side of the body and difficulty in obtaining blood pressure on one side of the body, or just a discrepancy in the blood pressures being more than 10 millimeters mercury difference. These patients may also present as hypertensives or even come in renal failure or with other cardiovascular events like heart failure or strokes like in our patients. To make this diagnosis, you need to do an angiogram, which will show you the irregular cell wall with areas of stenosis and areas of dilatation, what we describe as beading on the angiogram. Then for Wegener's granulomatosis or GPA, we know the involvement of the upper respiratory tract. So the patient may have chronic rhinitis, chronic sinusitis, or otitis media. And also with GPA, we know about the involvement of your pulmonary system and the renal system. So the patient may have glomerulonephritis or may even come with hemoptysis if they get pulmonary alveolar hemorrhage from lung involvement. Then EGPA, the commonest presentation is with obstructive lung disease. These are patients who have asthma, which is usually refractory and difficult to treat. And they also have upper respiratory tract infection, involvement as well. If you see palpable purpura, you have to think of more of cutaneous vasculitis, which is usually associated with diseases causing small vessel vasculitis. So these are just features that will help you to localize the type of vasculitis going on. So until recently, we've been using the ACR 1990 classification criteria that was proposed to help us classify some of these primary vasculitic syndrome. It's interesting to say this ACR 1990 classification has never been validated, but it's been helpful for use in research and in clinical practice to help us make diagnoses and classify patients. So recently, just a few months ago, the ACR and EULA, the American College of Rheumatology and European Alliance of Associations for Rheumatology, have come up with validated classification criteria for some of these primary vasculitic syndromes. So far, they have published 3 of them for GPA, for MPA, and for EGPA. I'll briefly take you through these new classification criteria. So for all of them, as you will see, there are entry criteria that you need to satisfy. You should have made a diagnosis of small or medium vessel vasculitis before applying this criteria, so that you do not get false positive and you do not fall in the trap of overdiagnosing. Also, you should have ruled out any alternate diagnosis or ruled out other conditions that may mimic vasculitis. The criteria has 2 broad domains, your clinical criteria and then laboratory imaging and biopsy criteria. And these have features that are weighted and you get a sum of it. For GPA, if you get a sum of at least 5, then you can classify the patient as having granulomatous polyangiitis. So your clinical criteria, your upper respiratory tract involvement, and also your ENT involvement give you positive points. If you look at the laboratory imaging and biopsy criteria, presence of a C anchor, presence of a C anchor, and then your lung involvement, your kidney involvement, and your biopsy results also give you positive points. You don't expect to have P anchor positivity or eosinophilia in GPA. So the presence of that gives you negative points, and then you sum up all the weighted points. For EGPA, still the same entry criteria of ruling out differentials and establishing that there is small or medium vessel vasculitis. The obstructive airway disease, which we usually present as asthma, nasal polyps, and the CNS involvement will give you positive criteria. Eosinophilia in the blood is a strong positive point, and then your biopsy result also showing eosinophil infiltration gives you positive points. Presence of C anchor or renal involvement, which you do not expect, give you negative points. And a sum of more of at least 6 helps you to classify a patient as having EGPA. For MPA, same entry criterion, and then you don't really expect to have these upper respiratory tract manifestations. So the presence of it gives you minus points, and then a positive P anchor gives you a strong positive point. Lung involvement, renal involvement gives you positive points, and you C anchor or eosinophilia will give you negative points because you are not expecting that in an MPA. So for us, what's our general approach to treatment of vasculitic syndromes? First, you need to identify and remove or treat any inciting agents. So if there's an infection, we need to treat it. If we think it's secondary to another systemic disease, you need to treat it. And if it's a drug, you need to withdraw the drug. The treatment is usually with immunosuppressive therapy, and you need to initiate immunosuppressive therapy according to the extent of the disease. So how you will treat maybe small vessel vasculitis showing cutaneous vasculitis will be different from how you treat vasculitis affecting the kidneys or the lungs, causing organ-threatening disease. And the treatments we use, these immunosuppressants have complications which we need to prevent whilst we treat. The cornerstone of treatment is with steroids to induce remission and then to maintain patients on steroid-sparing agents. But when we've got severe relapsing disease, refractory disease, or organ-threatening disease, we hit harder with drugs like cyclophosphamide or biologics. And we always have to remember to treat the underlying disease. I'll just go through a few of the vasculitic syndromes and how we treat the drugs we use to treat them. So for giant cell arteritis, glucocorticoids are mainstay of treatment, first line, and then we use steroid-sparing agents, methotrexate, azathioprine, and leflunomide. Cyclophosphamide and anti-IL-6 tocilizumab can be used for severe disease, and low-dose aspirin is recommended for use to prevent cardiovascular events. Takayasu's arteritis also treated with steroids, and methotrexate, azathioprine, leflunomide, and mycophenolate mofetil can be used as a steroid-sparing agent. For severe disease, we can use cyclophosphamide, IL-6, anti-IL-6 tocilizumab. We can use TNF-alpha inhibitors, infliximab, and then we can also use our IL-12, 23 antibodies with ustekinumab. Low-dose aspirin is also recommended here to prevent cardiovascular events, and also you have to institute strategies to reduce cardiovascular risk, like lipid reduction therapy, controlling the blood pressure, and others. Surgery is not commonly done, but it can be indicated when you've got persistent stenotic lesions causing persistent symptoms that are refractory to medical therapy. So you can do angioplasty with stents, insertions, and bypass grafts to help reestablish perfusion of the target organs. Polyarthritis nodosa, similar treatment with steroids, methotrexate, and azathioprine as your steroid-sparing agents, and you can use cyclophosphamide or anti-CD20 rituximab for severe disease. So until now, we've been using the recommendations from 2016 EULA to manage the ANCA-associated vasculitis specifically. So I've spoken about the large and medium vessel vasculitis, but with ANCA-associated vasculitis, this is the recommendation we have from 2016 EULA. If you make a diagnosis of ANCA-associated vasculitis, you have to determine, is this a non-organ threatening disease or is it an organ or life-threatening disease? If it's non-organ threatening disease, you can induce remission with methotrexate, mycophenolate mofetil with steroids. And if the patient goes into remission, you can put them on maintenance therapy with azathioprine or methotrexate, which is advised to be given for at least 2 years before tapering. If there's organ or life-threatening disease, then we give cyclophosphamide or rituximab with the steroids, and then we maintain the patient when they go into remission with either rituximab or switch to the DMARDs and treat for at least 2 years before stopping or tapering treatment. For patients who come with rapidly progressive disease like pulmonary hemorrhage, renal failure, plasma exchange can be considered to sort of acutely remove the offending antibodies from the system. So what's new here? Just recently, just ended EULA, there have been updated recommendations for the treatment of ANCA-associated vasculitis. This is yet to be published, but it was presented at the last EULA Congress. And what they have done is that based on some strong randomized controlled trials that have been done to show the efficacy of these new drugs and have improved the standard of care of ANCA-associated vasculitis, these recommendations have been made. There are new drugs that have been recommended. The first one is avacopan. which is an anti-complement fiber receptor antagonist. If you remember when we went through the pathogenesis, when your antibodies identify your anti-neutrophilic cytoplasmic enzymes MPO and PR3, it causes activation of the alternate pathway with C5a production, which causes a lot of damage with endothelial growth factor release. So this drug sort of mitigates that process. And I've listed some articles at the bottom of the page, which have shown that it is non-inferior to using steroids with your cyclophosphamide or rituximab, and actually showed some superiority in maintaining remission. So this has been introduced as a drug that can be used for induction with cyclophosphamide or rituximab to help mitigate against the side effects of steroids, and also to help you to be able to taper your steroids quicker. Also, mepolizumab, which is an anti-IL-5, has been proposed as a drug to be used in EGPA. This causes a reduction in your eosinophil count and helps, and has been shown to help with refractory or relapsing eosinophilic granulomatosis with polyangiitis. They've also revised their recommendation on the use of rituximab. So before, rituximab was an option to use for either from cyclophosphamide, but now it's been placed as a preferred option for remission induction in GPA and MPA with life-threatening or organ-threatening disease, and also has been placed as a preferred option for maintenance treatments. And methotrexate and azathioprine are mentioned as alternatives because of studies that have shown some superiority. The duration of maintenance therapy, remember from the 2016 slide, I said it's at least 2 years, but now they've recommended that it can be reduced to 1 to 2 years, and only when there's relapsing disease, you can treat for longer. And they also emphasize the use of cotrimoxazole prophylaxis in patients receiving these immunosuppressants to guard against infections. Another part of vasculitis that is very important that we need to make note of is to identify mimickers of vasculitis. These are conditions that can present clinically and even in lab investigations like vasculitis, but we need to recognize them because the treatment will be different and we cannot treat them the same way as the vasculitis that need immunosuppression. So the conditions that can mimic large vessel vasculitis include your fibromuscular dysplasia. So this can present like a female with hypertension and with renal failure, and on Doppler you may see narrowing of the renal arteries, but this is not a vasculitis on its own and you need to recognize it. Atherosclerosis, syphilitic aortitis can all mimic large vessel vasculitis. Medium vessel vasculitis mimics cholesterol emboli syndrome, and atrial myxoma, and also fibromuscular dysplasia. And small vessel vasculitis may be mimicked by infective endocarditis, antiphospholipid syndrome, sepsis, example meningococcal septicemia, and drugs, your ergot drugs, your methamphetamines, and calciphylaxis, especially in renal failure, may mimic vasculitis on the skin. So for us, when we suspect vasculitis, there's no single presentation, but you have to think about vasculitis when you see patients presented with multi-system inflammatory disease, especially if they're constitutionally ill. Skin lesions like palpable purpura livido reticularis, which should also make us think of possible vasculitis. And when we've got ischemic vasculitic changes like digital gangrene, glomerulonephritis, mononeuritis multiplex, inflammatory ocular diseases like uveitis, and when we've got an unexplained elevated ESR, it should light up a bulb and make us think about possibility of vasculitis, and then work up and work it up, assuming there's no other diagnosis to explain these conditions. And then what do we do to try to make the diagnosis? Full blood counts will help us to pick up eosinophilia of, for example, EGPA. The acute phase reactants will be raised, especially your ESR. And then you also need to work up to find the extent of organ involvement. You need to do your renal function test and your urinalysis. you need to image the lungs to see if there are any infiltrations that you expect from the small vessel vasculitis that have lung involvement. Your liver function test. With mononeuritis multiplex, you need to do your nerve conduction studies. And then for serology, your anchor, you need to do your anchors. Just a brief word on anchors. Lots of people do anchors without any proper indication, and sometimes they get a positive test and you really don't know what to do with it. So you should have a good reason for doing an anchor. For example, if a patient comes with a large vessel stroke, you don't really need to do an anchor, because remember, it's associated with your small vessel vasculitis and sometimes the medium vessel vasculitis. So you should have a good suspicion of small vessel vasculitis before doing an anchor, because there may be false positives, which you cannot really place anywhere. And also the antibodies, you can have antibodies to other enzymes in the neutrophil cytoplasm, like catepsins and all, but the specific ones we have to look for is that against myeloperoxidase and proteinase 3. Then your autoimmune workup to see if there's any associated autoimmune disease, and then cryoglobulins will help you to diagnose your cryoglobulinemic vasculitis. Imaging is important to pick up the blood vessel irregularity, your stenosis, and your aneurysmal formation. And then the organs that we can easily assess to biopsy to pick up the vasculitis will be your skin, if there's lung involvement, your kidneys, and then the temporal artery in the case of giant cell arteritis. We also have to do tests to rule out differential diagnosis. This is very important, because if you pick up, if you realize that it's not actually primary vasculitis, but from other causes, you need to treat that rather. So viral serology for HIV, hepatitis, you need to do an echocardiogram to rule out some source of emboli, blood cultures for infections, and then urine toxicology. Remember, we mentioned that some recreational drugs can present with vasculitis. Then the take-home message from all of us, students, registrars, physicians, specialists, subspecialists, we should suspect vasculitis based on the features that we have discussed. When you see vasculitis, you have to define the extent of the disease, and very importantly, rule out the vasculitic mimics, because that will decide how you treat the patient. Investigate for a secondary cause and treat. Confirm the diagnosis with the investigations we've gone through. Multidisciplinary team management is very important, because like we said, it can affect anything, ENT, the ophthalmology, pulmonology, renal, can affect any system. So, and we need to have a multidisciplinary approach to managing these patients, and treat according to the extent of disease. If it's mild disease, or whether it's severe life-threatening or organ-threatening disease, your choice of treatment will be different. And remember to always look for possible underlying systemic disease and treat that into remission. I hope I've been able to do justice to the topic in the time assigned. Thank you. That's the end of my presentation.